Very good afternoon to everyone. It's a pleasure to see you all again. Like I said, I gave the inaugural talk and I'm going to give the closing talk. And I thought probably only few people will be here, but I'm quite happy to see quite a lot of people here. And I would like to thank Dr. Migdari for trusting me and giving me this opportunity. And so I'm going to talk for the next 20 minutes on how to interpret a liver function test. This talk has been specifically designed for practicing pediatricians that would be useful in day-to-day practice, how to analyze when you get the results. So I'm from Dr. Rela Institute from Chennai. This is the hospital where I work, and we do quite a lot of pediatric hepatobiliary work. Coming to liver disease in children, there are hundreds of liver disease. So it's practically not possible for me to go through each and every disease and give a specific how to diagnose. So what I'm going to do is to talk on few common disease which you come across on day to day and how to interpret. And I want this session to be a bit more interactive. I would like the audience to participate in it and give some prompts, some answers when asked, so that it's much more interactive. Otherwise, it might be quite a dry talk. So you have two cards. You need to go to a place and you have given option A, the top one, option B, the lower one. Which one would you choose? A. How many choose B? B. Yes. So essentially, B is quite attractive and that looks fantastic. But yeah. So A doesn't look good on the outside, but it has a fantastic engine inside and it drives you so fast. And B, though cosmetically nice outside, it doesn't have an engine inside. So it's not going to take you anywhere. So that's true for your liver as well. Your liver can look absolutely fine on ultrasound or when you take it out, but it might not work. Or you can have like a quite damaged liver, cirrhotic liver, like in congenital hepatic fibrosis, where the liver will be quite big and looks ugly, but it will work fine. So based on this, I'm going to go through some cases and so that you can rethink about this. So you have this concept that the liver can look bad, but it works well. It can look absolutely fine, and it doesn't perform its function. So what is liver function test? Basically, we can categorize into two. One is to look into the cellular integrity. Hepatocytes, cholangiocytes, when these cells have certain enzymes inside it, when they rupture or get damaged, these enzymes come out into your blood, and we do a blood test, a biochemical test, and we find out. That tells about the integrity, cellular integrity. Then comes the structural integrity. As I said, the external cause. It's usually like when cirrhotic, the liver goes for fibrosis and nodule formation. So for the structural integrity, you need ultrasound, CT scans to see the structural integrity. So first, let's go into the cellular integrity, how we look into the cellular integrity, what are the tests, and how we actually look into it. So what is liver function test? Is it one test? It's multiple tests. So liver function test is not a single test. It can be a biochemical test. It can be a radiological test, endoscopy, look for varices and say you have liver fibrosis, a genetic test, histology. So it consists of multiple things. So you need to sort of put the puzzle together to get an understanding. So one simple test is not going to give an answer. So it's a multitude of tests which you need to, just like putting up the puzzle, and finally you will come up with an answer. So liver function test. So there are few enzymes which tells about your hepatocyte damage, few enzymes which tell about your biliary epithelial damage, bile duct obstruction, synthetic function, and detox function. So liver does several functions, and there are few common tests which we can do, and it can tell about where exactly the problem is. Starting with hepatocyte damage, we look at two enzymes, AST and ALT. That's quite common enzymes which we do, and essentially they help in sort of transferring these amino acids, and you know the normal values. So, and you know the normal values. So this is the reference range, and based on different types of involvement, different types of cell deaths, the numbers can go up. In liver cirrhosis, it can be in hundreds, alcoholic hepatitis in thousands, and in ischemic injury, even it go to 10,000s. So you see very high values in thousands in an acute insult where there is a lot of cell death, like acute paracetamol poisoning, acute viral induced liver failure. And in metabolic disease like Wilson's disease, it's usually in the hundreds. And we use AST, ALT as a surrogate marker in rejection. When it goes up slightly high, then we think there is some rejection going on in transplant scenario, do a biopsy to find and we treat them. And the ratio of AST is to ALT of more than 2.2 is helpful in diagnosing Wilson disease. But the AST-ALT has no correlation or with the cell damage, or it's not used as a prognostic marker. So the AST of ALT of around 100 is same as 200 as 300. So we can't make out anything about the liver damage when it's high. When it's high, we can say, yes, there is some damage happening on, but we can't define how severe the damage is. So let's go to first case. We have a 2-year-old child who has some abdominal pain. So came for your routine visit. And then you found out the enzymes are high. AST-ALT is high, but the bilirubin, ALP, INR, ultrasound is normal. What is the next step? Anyone? Repeat. Okay, you're repeating it. Again, it comes the same. Biopsy, genetic test. Child is absolutely fine, running around. HAV is coming as negative. Don't forget the myopathies. Many children with raised enzymes, as I said, it's not coming alone from your liver. The AST and ALT can come from your muscle. So when you have raised enzymes, always check your CPK. So that's the message from this slide. Yeah. And then we'll go to the biliary epithelial damage and bile duct obstruction. So we look at 3 enzymes, gamma GT and alkaline phosphatase. 5-NT is not usually done in any of the labs, so we'll skip that. So we'll look into the gamma GT and alkaline phosphatase, how we can utilize in diagnosing certain disease. So GGT is produced by the epithelial cells, and it also produced from renal tubules, pancreas, and it's elevated in pancreatic disease, alcoholism. So how it's useful in diagnosing disease? Many conditions, when there is a cholestasis, the GGT goes up. And like neonatal sclerosis, cholangitis, Alagille, whatever it is, when there is a jaundice condition, the GGT goes up. But there are few conditions where the GGT is low. Even with cholestasis, PFIC type 1, type 2, type 4, a benign recurrent intrahepatic cholestasis. So it's quite helpful in a neonatal period, a child with jaundice, where they have high bilirubin and a normal gamma GT or a low gamma GT, then you think probably they have one of the disease. A low gamma GT is more helpful in diagnosing this disease. Again, we're coming to a case. There is a 2-week infant and had some neonatal jaundice, pigmented stools. You're not thinking of biliary atresia, and this child has AST-ALT normal. Child had higher bilirubin initially. At phototherapy, everything is getting better. But the gamma GT is high. Ultrasound is normal. Child is absolutely fine. What would you like to do? Anyone want to prompt? Observe. Yes. Anything else? Any disease? Sorry? Milk. Uh, breastfeeding child. Okay. We need to look at the nomogram. So the gamma GT at birth is not 50. At birth, the gamma GT is around 400. So, and then it reaches the adult value by around 9 months of age. So when dealing with pediatrics, make sure you look at the reference range, because all the reference range printed on the lab on the site is not for children, it's for adults. And this is the nomogram for a gamma GT. So newborn levels can be up to 10 times more, and high levels can tell about biliary disease, but it's not going to tell whether it's an intrahepatic problem or extrahepatic biliary disease. Moreover, a low gamma GT is more helpful in diagnosing this PFIC. We'll move to alkaline phosphatase. Alkaline phosphatase secreted from bone as well. In children, high alkaline phosphatase can be due to rickets, due to vitamin D deficiency, fractures, but also with a liver disease, the alkaline phosphatase goes up. And alkaline phosphatase is low in zinc deficiency. And usually we need to have a gamma GT along with it so that we can tell whether it's from bone or liver. It is quite helpful in one condition. In Wilson disease, alkaline phosphatase to the total bilirubin ratio of less than 4 is quite suggestive of Wilson disease. In Wilson disease, the alkaline phosphatase levels are quite low for some reason. Probably they have associated zinc deficiency, and it's one of a sensitive marker to tell about Wilson disease. Coming to bilirubin, I think you have unconjugated bilirubin during newborn period, hemolysis. There are a couple of conditions which give you unconjugated hyperbilirubinemia, only a couple of conditions. Crigler-Najjar syndrome and Gilbert's. Gilbert's you see in 3% of population, so it's quite common. And Crigler-Najjar, the bilirubin is usually sitting at 20 to 25 milligrams. And when you do phototherapy, it comes to 50. And essentially, these children would require transplantation. Coming to conjugated hyperbilirubinemia, which has quite a lot of disease and hepatobiliary diseases. So we have a child who had phototherapy. The bilirubin is in milligrams. Normal is usually less than 1 is normal. So the child has a total bilirubin of 12 and a conjugated fraction of 0.9 milligram. This is a 2-week-old child. And this child had phototherapy a week prior, it was high. It's coming down now. AST/ALT fine, INR normal. Are you happy to discharge the child, or do you want to bring the child back to the clinic? What do you want to do? Discharge. How many of you want to bring back the child? Is there anything worrying in this report? There is something worrying in the report. By definition, neonatal cholestasis, a conjugated bilirubin of more than 1 milligram when the total bilirubin is less than 5 milligram, and 20% when it's more than 5 milligram. That's how neonatal cholestasis is defined. In children less than 2 weeks of age, any bilirubin of more than 0.8 milligram or 10% should be followed up, because many of these children can have problems like biliary atresia. Because most of the time, the biliary atresia, as doctor was talking about, most of the time you get a history that baby had a newborn jaundice. But when you go back and look back, the conjugated jaundice fraction, usually they'll have 1, 1.5, which usually get missed. So any bilirubin value of more than 0.8, these children should be brought back to the clinic and made so that it's getting better. So we have gone through hepatocyte damage, biliary, epithelium, bile duct obstruction. Let's look at synthetic failure. So liver produces a lot of things, but there are a few things which we can do test easily. And one is coagulation, INR, albumin, cholesterol usually don't use for as it is synthesized by the liver. And then coming to coagulation, so you have the coagulation pathway. All the factors are produced by liver apart from the von Willebrand factors. So all the factors are produced by your liver. The red ones highlighted are vitamin K dependent. And essentially, when there is vitamin K deficiency, you can have coagulopathy. And that's why in acute liver failure, in definition, they say you need to give vitamin K. And after vitamin K, you can recheck the INR in 6 hours to see whether the liver function is, whether the INR is getting better. So with the factor deficiency, it's a very sensitive marker and it's used as a prognostic tool in acute liver failure. In chronic liver disease, again, you can have coagulopathy, but usually they don't define liver transplant criteria with INR in chronic liver disease. And then albumin is an important surrogate marker for chronic liver disease. You have a half-life of around 20 days, but low albumin tells the disease is quite chronic and you can have fluid distributed outside your vascular space, causing a lot of trouble. And children with ascites, usually in adult practice, they give albumin when they look at a low albumin. But in pediatric practice, usually we don't transfuse albumin unless they have respiratory issues or the ascites is so severe that it's compromising the breathing. So just by a value of 2.5, 2.2, you don't just transfuse albumin. Only if there is some issues with the respiratory decompensation because of the large volume ascites or having low urine output, then we transfuse them. And finally, ammonia is detoxified by your liver. In metabolic disease, the ammonia can go up to several thousands and essentially would require a hemodialysis. But in chronic liver disease, it can be 200, 300, and it can be a surrogate marker, particularly when there is a portosystemic shunts. When you look at the ammonia, when these children are having like Abernethy malformation, where these children having learning difficulties. Okay, we finished with that component, and then we are looking into alpha-fetoprotein. You know, alpha-fetoprotein is something common, and I do get calls based on this alpha-fetoprotein. So you have a prem child having a bit of conjugated jaundice, premature child, and was on TPN for a while. And for some reason, the resident has done an alpha-fetoprotein of 2000, alpha-fetoprotein, and it has come as 2000. And everybody is worried. They want to do scans. They want to rule out tyrosinemia, this and that. What is the next step? Repeat. You are repeating again, it's coming the same. Yeah, I think that would help you. You can see a declining trend. Again, as I said, the nomogram is entirely different. It's alpha-fetoprotein is a fetal protein. So even premature babies has a quite high levels, and essentially it comes to normal range only after they are like 2 months, 3 months of age. So as I said, if you have a high level, one value doesn't mean anything. You can repeat it after 2 weeks to see a declining trend, but you need to look for tyrosinemia if it's one condition where your alpha-fetoprotein is high in infants with cholestasis. So whom are you worried about? You do a scan on a child coming for some constipation, something you are doing, and then you find out fatty liver. Whom are you worried about? This guy or this guy? Thin guy. This is for general pediatrician, Mohammed, not for you to answer. Absolutely right. The thin child with fatty liver is the one whom we are worried about. And there is guidelines suggesting that children less than 10 years, whether you are thin or whether you are obese, whether your enzymes are normal, liver enzymes are normal, abnormal, always they need to be investigated. Only children who are more than 10 years, obese, we can put them on weight reduction program for 6 months, re-evaluate them, and then go for a biopsy. Because these are few of the conditions which can cause fatty liver in children. Wilson disease, autoimmune liver disease, cystic fibrosis. So lean child with fatty liver, you should be worried, and these children has to be referred. Obese children with fatty liver, you can put on diet, wait for some time, and then you can re-evaluate them. Giant cell hepatitis. I think this is something quite common in the newborn period. You have cholestasis, you do a biopsy, and you get giant cell hepatitis. You are happy. How many of you are happy that it's not biliary atresia, it's only giant cell hepatitis? You are happy. But the problem is 20% of them might get a progressive disease and can go for a liver failure. And usually when you have giant cell hepatitis, always check Coombs positivity, because if they are Coombs positive, they are associated with bad outcome. And also, more recently, what we found out is type 2 PFIC. It mimics giant cell hepatitis. So the biopsy will look exactly like giant cell hepatitis, but only when you immunostain them, you can find out that it is BSEP deficiency, type 2 PFIC. So a child with giant cell hepatitis, think of two things: PFIC type 2, always do a Coombs test. Coming to the structural component of your liver, I think fibrosis, whatever the disease is, ends with fibrosis and cirrhosis. And how do we evaluate them? We can do a biopsy. Now you have a fibroscan where you can evaluate the structure of the liver. Just another 2 slides. You have a 3-year-old child, a successful Kasai, defined by they have bilirubin is normal, slightly raised enzymes, which is quite common in those children, which is absolutely fine. They have a slightly enlarged spleen, platelets on the lower side. They have portal hypertension, which we accept. So how do you evaluate the child for cirrhosis? How many of you would do a biopsy? How many of you would do a fibroscan? Fibroscan biopsy? Fibroscan. Yeah, many people think fibroscan, they can do fibroscan because it is non-invasive. But there are people who have done biopsy as well. But the truth is, we don't need either of this investigation, because what we are looking at is functionality of liver. These livers might have grade 3 fibrosis, grade 2 fibrosis, grade 4 fibrosis. It doesn't matter. What it matters is how it's working. So our decision making is not going to be based on the cirrhosis of liver. Our decision making for whether the child needs a transplant is based on whether the child becomes cholestatic, whether the child has liver failure, on other parameters. So in children with liver disease, doing a fibroscan, and it only worries the parents that they come with the report, oh, my child has a fibrous liver. It doesn't matter. As long as the liver is working well, that's why I put the first slide of the 2 cars. As long as you can drive the car and it's moving, fine, you drive as long as it lasts. So this is the final slide. A 2-week-old girl child with prolonged jaundice, conjugated jaundice, hepatomegaly, and hypoglycemia. You have ruled out glycogen storage disease, and the baby is quite tiny. Length and weight are in the 10th centile. All metabolic tests you are doing, it's negative. Child is hypoglycemic. Child is in your NICU. Think of some endocrine cause. Sorry? Yeah. So what is this? Fantastic. It's a septo-optic dysplasia. So the most important adjuvant to your liver function test is a good history and a clinical examination. I think if somebody is going to come with a report and give you to assess the condition of the child, you just give it back and say, no, it's not possible. You have to see the child, do a good clinical examination. You have to correlate that with your liver function test. That will give you the answer. Just by looking at a report, you can't tell whether the child is bad or whatever is needed. So always have a good history and a good clinical examination of the child. So in conclusion, LFTs, it's not a single test, it's a multitude test, and you need to put the puzzle together to get the answer. I have told you on some common scenarios which you can work on in your clinics, and abnormal results has to be correlated with the normogram. So just don't jump into conclusions, and you should be aware of the normal range, because the normal range in your lab report is not for children, it's for adults. And always you should have a complete history and a good clinical examination. With this, I conclude my talk. Thank you very much.